Freedom Day is rapidly approaching, and many question the whole point of what are we going to do with masks following that happening. In this episode, we're going to cover the use of masks, particularly in the healthcare settings like general practice and hospital environments, how that's going to be today, how that's going to be in the future with Freedom Day rapidly approaching, and also what this means in the longer term for your healthcare and your experience of general practice and the NHS. Let's tech enhance your primary care and learning. Hey, GB learners, and welcome to this episode with myself and Andy as we're talking about masks in healthcare, as well as wrapping up on how we've been over the past few weeks and various other stuff as well. How are we doing there, Andy?
Yeah, I'm pretty good. Enjoying myself over here in my end of Nottingham. Looking forward to talking about face masks and Freedom Day. Woohoo!
Yeah, so not too long. So just so people are aware, if you are watching this on recording and stuff, and hi if you are, we're recording this on the 10th of July and Freedom Day supposedly the 19th, unless something changes in that time frame. And it'd be interesting to see what that means in terms of general healthcare and everything else, and in particular use of masks, which is already, I think, becoming something that people are forgetting about if you're looking at all the media and all the other kind of stories and social media posts and stuff. Is that your experience, Andy?
Yeah, I think so. We're going through a phase of needing to remind people a little bit more in practice to wear their masks. So I think the public are beginning to let their guard down, following probably some of the sort of rhetoric coming from the government and some of the expectations about what might happen on July the 19th, aka Freedom Day.
And it's interesting the timing of this. Obviously, the whole point that I think many people are looking at is trying to look at how we open up, obviously, England and the UK and stuff in terms of post all lockdowns elements, and also trying to time that right with obviously the flu pandemic, the flu episodes and everything else that's likely to happen come September and everything else, and just basically what it means for all of us. It is confusing, it's difficult, and I think there's always going to be times when people kind of get it right and get it wrong. But specifically, when we're talking about masks and stuff, you're right, a contentious point of view, isn't it?
I think so. Yeah, kind of just a thought on the general policy in the UK at the moment, because it feels to me like the unofficial policy, unless I've missed something in terms of the messaging from the government, appears to be that we're going to tolerate higher infection rates, drawing some reassurance that a high proportion of the adult population is vaccinated, and almost allow a higher infection rate to happen at this point in time in the summer when the NHS isn't facing its sort of annual flu and winter demand crisis, and perhaps even aiming for an element of herd immunity amongst those people not currently vaccinated, sort of let it spread through the population in the summer, in the hope of avoiding something similar happening in the winter. Is that your reading of the overall sort of situation?
Yeah, it seems like there's this policy that they're hoping that although the infection rate's going up, that it should hopefully mean not as significant levels of hospitalizations, and worst outcome obviously being death from those hospitalizations as we saw in the earlier surges and stuff, and that the vaccination program will offer us an element of protection. And like, our politicians keep reminding us, we need to learn to live with COVID and stuff. I guess the concerns many people have is, what does this mean in terms of where's that level of it not being quite right, and also actually the fact that all the healthcare services are still under massive strain, got real issues in terms of workload, in terms of trying to cope with a lot of the surging and stuff, and also we've got a really tired workforce that have been literally running 100 miles an hour for the past 18 months, and we're about to head into flu season as well, which is a concern I think many people have, given the fact we're already at overcapacity before we even hit into it. So what does that mean again moving forward? It's difficult. Yeah.
And unvaccinated vulnerable people, or people in whom vaccinations are known to be less effective due to their immune compromise, etc. It's going to be an interesting few months to see if the government holds to this policy, if there's any backtracking, and how it pans out for the UK. Interesting times. But Gandhi, we've been away from people's screens, or at least in live format, for the last few weeks. We've been up to some interesting stuff. Yeah, what's been your kind of highlights from the last few weeks, just to make people aware?
Sure.
We've
So
been a good
I
way.
think the big one for probably both of us has been the System on Facebook Users Conference that we ran just over a week and a half ago. It was an amazing experience, having loads of people engage with it and stuff. And we had a great time producing that for all of our EGP learners and those members, using System 1 and stuff. Hats off to TPP. They definitely brought the stuff. So if you haven't heard about some of the announcements that came at that conference, oh my gosh, there's some awesome things coming. And definitely our sponsors were massively supportive of that in terms of delivering an amazing experience to everybody. And if you do want access to the recordings and stuff, let me know. There's links in the description and stuff to access them if you did miss out. But interestingly enough, we're doing it sort of again in just a few weeks' time as the HTN Digital Primary Care Conference, where we've got some, again, amazing experiences for people and some keynote speakers that are absolutely the type of people you want to watch. So Dr. Nikki Kanani, a Director of Primary Care, talking about the future of general practice, and Dr. Min Albakai talking the future of digital general practice. And absolutely, that's a key thing with obviously this whole contention between face-to-face and remote care and stuff going on, as well as some awesome sponsors and stuff. And this one is free, so you don't have to pay anything to attend. And if you do want to join, again, links in the description down below. Definitely check it out. That's live and it's with our partners HTN. So those have been probably the biggest highlights over the past few weeks in terms of what we've been up to outside of trying to produce content. What about yourself, Andy?
Yeah, I'd share those highlights. And as ever, the primary care network and general practice, remains busy. All sorts of things happening there, and yeah, begin to have conversations about flu season and co-administration of flu vaccine and COVID booster and all of these issues that are going to be affecting us all in a few months. Just beginning the preparations to plan for those things amongst a lot of other stuff.
Yeah, and just so people are aware as well, we've had some interesting news. Both myself and Andy are going to be delivering a session at the annual RCGP conference in Liverpool in October. So if you want to come and check us out, talking about content creation and basically how to have a portfolio career as a GP and in all the kind of stuff me and him do, feel free to come and join us on Friday at the RCGP conference on the 15th of October, although it starts on the 14th and stuff.
I think that's right.
Yeah.
Fantastic. Yeah,
and we're going to be streaming throughout the conference as well, so hopefully we'll be able to keep you all updated even if you don't attend and stuff, as we tried to do as I tried to do last time, and obviously last year's conference didn't happen because of COVID and things. But yeah,
but do attend and come and join us and chat with us there.
Yeah, we may even do live interviews with people. How awesome would that be? Cool. And we've got another one if you want to jump in and join us, and that's going to be the UK Games Expo, which is where we're going to be live streaming from in 2 weeks' time.
Awesome. So
back to the topic at hand.
Face masks.
Yeah.
Gandhi, there's a lot of anxiety amongst my staff actually about Freedom Day. I've got the Sky News article up about Freedom Day. The media are making a really big deal about Freedom Day and that most of the restrictions placed on general public in terms of social distancing and in particular and particularly controversially mask wearing are felt to be likely to go on July the 19th. And a lot of the staff at the GP surgery, administrative, reception, clinical staff are beginning to ask questions. What are we going to do on July the 19th at the surgery? What will that mean for me wearing a mask as a member of staff at the GP surgery? And what will that mean for the patients coming into the surgery? Because we still have members of staff who have vulnerable people at home. They might be vulnerable because of health conditions themselves. The majority are vaccinated, but we know that doesn't give 100% protection. And we know that infection rates are rising despite the loosening of these restrictions that have been placed on people. So it's becoming a big issue in practice.
It is. And I guess just before we get into the discussion itself, key to remind everyone that myself and Andy are by no means specialist knowledge people on this particular area. We're giving you just our opinions on the information we have at this point. I guess on that particular part of what this is meaning for general practice in particular, we don't know because they haven't actually announced what the actual advice is for healthcare settings specifically come July 19th, and how that may or may not change. Current guidance is still that you wear a mask in a healthcare setting. So that is the current IPC guidance. And if patients feel that's not something they need to engage with, there is, as per we have been doing for the past year and a bit, the guidance is exactly the same as what it has been. So hopefully everyone is aware of what they should be doing, how they should be doing it currently. We're going to talk about kind of what that guidance has meant lately, aren't we? So there's been a few things that have come up in terms of case studies and that kind of stuff. I know you wanted to talk about those, didn't you, Andy?
Oh yeah, well, I just as part of the preparation here, I just sort of wanted to recap on some of the kind of evidence and principles around mask wearing in general, really, because we obviously we assume it's a good thing. I'm sure many of the people out there have looked into the evidence in more detail than I have. But I had a Daily Mail article up to keep it that Gandhi made me take down, not to use. But that was an interesting example of how confusing this issue around the evidence can be, particularly for members of the public, because that article did draw on a few scientific studies, but presented the impression that science was split on the issue of what they said was how effective masks are, but the implication of how it was written was they were sort of implying whether they were effective, but actually what they were saying is scientists can't decide on how effective they are because there is significant evidence that they are effective, but where there seems to be some controversy, or not controversy, but some scientific debate is around how effective they are and how effective different types of masks are compared to each other. There were two. I applied my usual initial Google search sort of criteria for looking for evidence, which is not particularly rigorous, but it does throw up some interesting things to talk about. So there was a good article from the BMJ, just really looking at the current situation around masks and particularly focusing on cloth masks and different types of masks. And there was a good article on in Nature as well. Here's an image from the 1918 flu pandemic of baseball players wearing masks. So, not a new intervention in these sorts of influenza type illness pandemics. So when people talk about the effectiveness of mask wearing, the articles of paper seem to fall into a number of categories. So there's articles that look at the sort of physical performance of masks and different sorts of masks and how they stop particles of certain sizes, and there are some assumptions as to what, or at least initially, as to what size of particle was relevant for the transmission of COVID-19, that masks stop particle transmission and droplet transmission to various degrees, and it depends on what type of mask it is and what materials are used and whether it has a valve or not. So were you using valve masks, Gandhi? Or have you seen many of those?
Not really many, not particularly by clinicians. I know I've definitely seen patients wearing them and stuff and pointing out, unfortunately, that they're not as effective as people may think, because they unfortunately can just create an exhaust pipe that basically means that can spread further infection from the individual. I guess the key thing with masks that we would like to point out, most of the evidence that is around there does say that the majority of the information is designed to protect the actual other people around the user from using when they use masks compared to actually the user themselves. So although it does potentially reduce transmission, particularly physical transmission by droplets and stuff for the user, it's actually most effective at trying to reduce transmission from the user to other people. And both people wearing masks is where you get the most protection and stuff. And I'm sure people have seen the infographics which show that kind of information in percentages and stuff. And something like if both people wearing masks, then it's something like 97% effective at reducing transmission.
Yeah, which is really powerful, and it highlights the kind of the population level importance of wearing masks, and there's a sort of a multiplier effect. The more people that are wearing masks, the issue of protection from infection from an infected person wearing the masks is there's quite an interesting case study from Missouri that you see referenced quite a lot of some hairstylists. So apparently there were two hairstylists who worked in a salon, and both were known to contract COVID-19, and they were wearing masks when dealing with clients and colleagues in the salon quite rigorously, but at home and in their social interactions they were not wearing face masks, and this little outbreak was looked at in quite a lot of detail, and they were able to identify that none of the clients, to their knowledge, who saw them when they were wearing masks got COVID-19. And whereas there were a number of cases of transmission to people in the environments where they were not wearing face masks. So that was interesting. And then in America, there are some population level studies looking at self-reported mask wearing behaviors in different states and different geographies within states, comparing that to the known R readings based on coronavirus transmission surveillance in those areas that does show a reduction in R values in those areas with greater mask wearing. So there's all sorts of case study and population level evidence that these things are helpful, essentially. So
I think one of the other things you found as well was about the concept of double masking, wasn't it?
Oh yeah, so Anthony Fauci, health advisor to Biden, and was in charge of the health response in New York, is quite an advocate of double masking, and apparently I've forgotten the statistics now, Gandhi. Now you've put me on the spot, but essentially wearing 2 masks is better than wearing 1, and there was a period of advocating double masking by this prominent scientist in the US to reduce transmission. So potentially wearing like a cloth mask and then a surgical mask on top. Those sorts of practices were advocated and may be helpful. But I guess that's not the direction that we're going in the UK at the moment, as we are going to have less masks rather than more.
Absolutely. And I think it's probably worthwhile we go to some of the comments we've had, because we've had quite a few comments already, and feel free to keep checking them in, people, in terms of enjoying them, the stream and stuff. So I know we've had some different comments. So from Jay Shapuri, he's mentioned with cases rising, I think it's more important than ever to continue to use them in practice. We've had multiple staff needing to isolate due to COVID infection over the past month. And I think this is one of the key things that obviously healthcare providers, the staff, the clinicians and things, if they test positive, they have to isolate as per the government guidance. And that has a huge impact on how a practice and the healthcare service can function, because they're not around to do the same level of service. Whilst they may be well enough to do certain things, like for example work remotely from home and stuff, that's clearly different than being physically present in the practice or the the hospital or whatever service to then provide healthcare and stuff. So that I think is one of the key things we need to be somewhat aware of and stuff. So there's that element of things to know. I mean, has this something that has affected you, Andy, recently? Obviously during the peak of the pandemic it was almost a weekly occurrence, but is it different now?
How do you mean in terms of people
staff
presenting
being off? Yeah.
Oh, staff being off. Yeah. It's becoming a little bit more of an issue now. So just on the practice WhatsApp this weekend, I think we've just had a member of staff say, "Oh, I've just returned from my break." So they've been away. They've done something that they've not been doing over the past year. They've been away on a sort of a little break holiday for a family birthday, and they've posted that one of their partiers tested positive for coronavirus. She's going to have to get tested. She's not sure whether she's going to be able to be in work on Monday morning. So I think it's going to become more prevalent. And also just looking at nephews and nieces and school bubbles, I think they've been bursting more often than they were a little while ago as well. But I think it's going to be a problem.
And it's been a huge issue with schools as well, hasn't it? Like you say, the school bubbles is having an impact on people in terms of testing positive, both in terms of direct contacts and indirect contacts and stuff. And as a result of that, kids having to be off school. That's happened to us. My son had to take an isolation period because one of his classmates tested positive, and therefore that meant he was homeschooled again, which was not a massive problem, but obviously the experience right towards the end of term, it's not a great one, is it? But it was what we had to do to keep everybody else safe and things. That impact in practice, if I had to suddenly work from home, would be sizable though, because in terms of the workload that's currently being faced by general practice, and not being able to provide those services because I'm required to isolate, that makes things definitely more difficult in practice and stuff.
And particularly with an increased emphasis on face-to-face appointments and trying to provide those, as we've discussed previously, that does increase the impact when a member of staff might have a booked clinic or a requirement to see patients face-to-face in that day that they're working is off and self-isolating. There's an increased impact that wasn't there to quite that same extent earlier in the pandemic, as people could do the majority of their work from home.
And as Jayesh mentions, again, we've had 3. This leads to an anxiety among staff that they may have caught it, and the main reassurance is mask wearing. So interesting point he's made there. I think it's further exemplified by Jez. So ultimately, we have a responsibility to our patients, our staff, and ourselves. When we see pathways coming in positive swabs and growing numbers, we need to make decisions to respond to that. So it does raise the question, what do we do moving forward? I think some counterbalance. So Maria's made a comment about the government stage meetings kept stating last year there was no big gains to be made from wearing masks, including reviewing RCTs. I think the evidence is tending more towards that actually masks are protective. They may not completely stop transmission, and nothing will 100% stop transmission, just like the vaccine is not 100% guaranteed to prevent you from catching COVID. Although it's showing, thankfully, that it is highly likely to prevent significant complications in the majority of people who have been vaccinated. So that's awesome news in that respect. But what are you thinking about moving forward, Andy? So, it's now July 19th and nothing else has changed, and the government plans are that the restrictions are, to be loosened. What are you thinking?
Well, I'm looking for some guidance for general practice going forward that would be helpful. And I don't think we've got any yet, but I think probably the actual intention of what will actually happen on the 19th of July from government, it may be still a little bit murky and potentially even subject to change. We have been having these conversations in practice, and we feel that mask wearing within the GP surgery will be an important part of controlling risk in that environment going forwards, which essentially I'm saying we would like people to wear masks going forwards when they're attending their GP appointments. We've got some anxiety as to what extent we will be able to force people or enforce that behavior in people going forwards. And we're anticipating, well, we have been getting pushback on masks throughout the pandemic from people who do not want to wear them and don't appear to have a good reason not to wear them. And we're anticipating an increase in that. People might feel justified in vindicating that behavior because of the attitude of the government and messaging from the government. So some messaging around healthcare settings would be really, really welcome from somewhere pretty high up in the government that we can point to when we're trying to enforce it. But yeah, I mean, I think we anticipate wearing masks, definitely members of staff wearing masks when they are in public facing environments. We've been having a discussion about relaxing or not in the office environment, and whether that would be optional for members of staff or not. And that's something that's still up in the air. We've got so used to wearing masks, and staff sickness is potentially going to be such a problem that we might stick with wearing masks sort of everywhere within the practice as we are doing now. It doesn't feel like it's a really big barrier to productivity, and people have got used to it. So it feels like the negatives of continuing with that behavior feel fairly minimal. And I extend that thought to the general public as well, really. It seems to be one of the less economically and sort of physically and socially intrusive things that we have been doing. So I do wonder whether mask wearing could have stayed generally. What are you guys thinking over at your surgery, Gandhi?
I think it's going to be challenging at times, like you say, because there is this concept of obviously the safety element, and with increasing cases, it's important to recognise obviously general practice and other healthcare environments are where the most vulnerable people will gravitate to, because they're coming to see us for their ill health. And obviously we have a responsibility, as Jez mentioned earlier, about protecting all of our patients, not just the individual patient that sat in front of us. And what does that mean? I know my personal view is tending towards that, patients and everyone should still continue to wear masks at the moment, because the cases are rising, and therefore the transmission effect is still potentially there in the background population, and particularly Nottingham, where we're working, actually, we're relatively high up on that list, actually. In terms of back office working and stuff, I know I'll be continuing to wear a mask even after July the 19th and stuff when I'm at work and things. And in terms of how we do the back office functions and stuff, I'll still be suggesting for our staff that it's a sensible thing to do, because I think it is. I think it's important to also recognise the impact that mask wearing has on communication in particular, and those that are genuinely their lives are more difficult because of mask wearing. So particularly, obviously, patients with learning disabilities, communication difficulties, those kind of things, where they do have an impact in how they can understand things and interpret things, and that element of things. I think physically, increasingly, we know that there's very few health conditions that will be negatively impacted by wearing a mask. And I know that there's going to be some people out there that don't believe and don't agree with that. But that's what a lot of the evidence does show, that masks do not negatively impact your physical health issues, generally speaking, apart from obviously for those that are in the extremes of things and stuff. So it is very much like a perception and an awareness perspective. That's not to say it's easy. I mean, you do get a bit hot and sweaty by wearing a mask, don't you, at the end of the day?
Yeah, and yeah, it's not just members of the public who have communication difficulties and so forth. We have a member of staff with some hearing impairment, and it's been quite difficult for them throughout the pandemic. That's somebody who works in in the admin team, but they have really struggled, and sometimes you just have to sort of take your mask off, move your mask aside, and so that they can lip read and just get that additional information from the movement of your mouth. But I'm just sort of thinking what it would be like to be a hearing impaired doctor or nurse, trying to do these consultations, and with patients where you can't see the lips. So it will have been quite impactful for a lot of people. So Gandhi, I'm going to sort of challenge you a little bit, because we're going to be getting these challenges in surgery from patients. So the sorts of things I'm anticipating the reception team will hear, things like, okay, the government no longer requires this, and I don't need to wear a mask when I go to the pub or the coffee shop. I don't need to do that there. There's lots of people there. They're busier than the GP waiting room. Why do I need to wear one in surgery? What's different about the surgery?
Okay, so I guess my response to that would be, number one, that the government advice is about wearing them in public places, and in general practice and healthcare environments are not public places. They're a place of business, but also a place of healthcare delivery, and actually is the responsibility of that business, the healthcare provider, to make sure they're keeping individual patients, staff, and other patients safe. So for that reason, mask wearing is still recommended as far as we're aware. They haven't changed the guidance on that. And again, to emphasize, the guidance on wearing masks in a healthcare environment has not currently changed. I think that's a key thing I would push across, because that is the main difference. There is loads of stuff about infection prevention control measures and stuff, and about the ventilation of spaces, about the size of spaces, all that kind of stuff, social distancing and impact and stuff. And while some of those restrictions may be loosened next couple of weeks, it's important to recognize that we are still delivering healthcare to potentially really vulnerable people, and that responsibility does not change, in my view. So that's going to be my answer.
Yeah, I'd agree. I think an answer that places the emphasis on practical things that the patient can kind of get a hold of in their mind, I think are going to be really helpful for us. So it's like, yeah, this is different. This is a healthcare setting. There are people here who aren't choosing to be here, like they might choose to be at a pub or a coffee shop. They need to be here because they need healthcare, even if they are still vulnerable or haven't been vaccinated or haven't been able to be vaccinated. They don't have a choice, and you're in that environment with them, and you will need to wear a mask for their protection. And also, I think the sort of staff sickness and absence and impact on service for them and other vulnerable people is another useful angle when we're having these discussions with people. But at the end of the day, they might say, you can't force me. I guess this is currently, there are government guidance and policy statements that we can lean upon in order to drive that home. And I guess we don't know what they're going to be after July the 19th. It may be that the government does mandate that it's still a requirement in healthcare settings, which I think I would really like to see. But if it's not required and patients push back, Gandhi, is there anything we can do? Open question.
I think it comes back to that element of providing safe and effective healthcare to all patients, and that's the part I think many people forget. Our responsibility is not just to the individual in front of us, it is to all patients, and we have to risk assess that. I think there are certain things that practice may need to adapt to. So there is obviously offering a mask to a patient if they don't have one, because that's potentially likely to be a situation that we see increasingly, because people forget to take them around with them and stuff. I think there's the option of seeing the patient at a different time, and although that has some complexities in terms of availability of workforce and that kind of stuff, there's other things that are sensible and recommended to do. And then there's potentially the situation of having red zones and that kind of stuff in practices, or amber zones, or whatever you want to call them. So different parts of the practice, you may see patients when they are saying that they can't wear a mask, or they have symptoms that potentially put other patients at risk, and that's no different to what we have done in other episodes of a pandemic or infection control issues. I remember when a few years back Ebola became a real big concern, and we had to say to patients, if you've got temperature and stuff, don't come to us. If you do have to come to us, we will see you through a particular route within the practice, because that's the safest thing to protect you as well as other patients and our staff, to make sure we're doing things as properly as we can. And I suspect we'll see a lot more of that from the next couple of weeks and things. So patients may need to be aware that they may not get the access that they want, but they will still be provided healthcare, because we still have that responsibility to provide healthcare. But if the risks are such that the clinicians and the practice feel it's above that element, then they may be directed elsewhere. And that's, again, something people may have to accept, that that's what they're choosing to accept.
Yeah, no, I agree. And sometimes actually when a patient is faced with a more inconvenient route of accessing care that maintains the safety of other patients and staff, often they become more willing then to wear a face mask, interestingly. So I think we still have those mechanisms available to us, I think, going forwards. Yeah, it'd be interesting. It all depends on what the government says, really, to strengthen our what's in our armory to get patients to comply with wearing face masks, because that's, I think, the right thing to do in the healthcare settings. Andy, what are you guys doing about access going forwards? Because we've had some conversations about sort of July the 19th being about the right time to look at our access model and proportions of face-to-face. Are we going to actually permit some patients with some problems to book directly into face-to-face appointments? We've been sort of having these conversations. Are you guys having those conversations? Have you come up with any plans? Where are you at?
So yeah, we're still having those discussions. I guess my personal view is still that all patients should have some form of remote contact before they book a direct face-to-face. That's not because of any specific. Well, the reason for that is often patients aren't aware, and even clinicians aren't aware, the reason for the contact that they're coming towards us with. So why book somebody in for a face-to-face contact when it's something that could be dealt with remotely, or more importantly, be dealt with in a different way? And having that pre-information, now whether that's online consultation, a quick telephone consultation, or something else, just to understand what the focus of that face-to-face contact is, I still think is really important. I absolutely accept that there are situations where a face-to-face contact is easier for communication in particular, and ease and that kind of stuff. And that's not to say that patients shouldn't then be offered a face-to-face contact, but it's just understanding the needs of that, and particularly the diversification of the workforce that we've got, so additional roles and that kind of stuff. Actually, there are more increasingly things that can be dealt with through other routes to make sure that we've got better availability for all patients. I'm going to make that point again. General practice is designed to provide healthcare for the individual as well as all patients, and trying to do its best with the limited funding that it has to do that. That therefore means that people may get a different experience moving forward.
Yeah, we were we had our initial conversations on this about 2 weeks ago, and the sorts of things that we were suggesting are beginning to feel a little bit too liberal to me now, actually. I think that's because some of the data around infection rates, particularly in Nottingham, has changed, and actually we're seeing like really high rates of infection in the general population, with people being infected, not feeling particularly unwell. And also there's a general feeling that people are not moderating their behavior and self-isolating and taking precautions themselves in the same way that they were in the past. So we were talking about making a proportion of our appointments available face-to-face for certain types of presentations. So certainly no respiratory presentations, or presentations with fever or COVID-19 infections. Those were all definitely to be telephone triaged again and dealt with appropriately following that. But certain selected presentations, such as abdominal pain, for example, we were going to give a free pass where a patient chose that their preferred method of first contact with the practice was face-to-face. We were going to, from at some undesignated point after the 19th of July, switch to a system where those presentations would be booked direct into a face-to-face appointment. But I now have concerns given the rates of infection. But we were looking to shift and move to a sort of a patient choice sort of model, where patients were guided based on their presentation as to what the most appropriate form of contact would be. You've got a rash, well, actually, that's probably best dealt with by sending us a picture and then having a telephone conversation about it. But you've got acute abdominal pain, but it doesn't appear that you're going to go to the emergency department with this, or it's not acute. Then yeah, come and see us at the practice, in a short short interval of time. We're moving towards that, but I don't know. Now, I'm not. That feels like it might be too liberal in view of infection data. What do you think?
I think it's important to recognise with whatever approach that practices and patients take, there are variables in every situation. So, how confident is the patient understanding what the health issue is? You'll have a different experience for patients based on if it's a acute on chronic issue. For example, a patient with Crohn's disease that's having acute bowel flare, that's a completely different situation with the type of abdominal pain presentation compared to somebody who's constipated, for example, which potentially just needs some simple management. And actually that pre-history information may help direct what kind of opportunity they need, and therefore the difference in system capacity within the practice to deliver that. Similarly, within practices, who's taking that pre-triage information will massively change how things work. Is it an automated process like AI within the systems? Is it a receptionist? Is it a clinician? All those different factors mean that it is different for every practice environment and how that outcome is going to work. So I will always emphasize that each practice should do what is best for the practice and for their patients, because they know their patients better than some central body, better than we do, to be honest. We know how our practices work. We know how our patients come to us and things. So we have a better understanding of that, but not for other places. But it is balancing the needs of what you have and what people are asking you for, and trying to find that, resolution really. But it's tricky.
Yep. Here. It's gonna be difficult plotting that route forwards.
And I think we go to a few comments just before we get to the next section.
We've had a lot of comments actually.
Yeah, we have. Jitin makes a really important point. How do you know who's coming to you with COVID? And that's one of the key things, that any patient with, there are patients with asymptomatic symptoms, which is kind of a misnomer, but patients who are asymptomatic that might carry COVID and they haven't presented with any symptoms. There are some patients that have symptoms and you don't know that they have COVID until they have a test, and they have the right test. That's the other part. Loads of people are doing LFT, lateral flow tests, and assuming that they are accurate, telling them that they've got COVID or not have COVID, when actually what they need is a PCR test. Having said that, Maria makes a point here. It's quite a long one, so I'll read it out for people. PCR testing is not picking up those who are infected and shedding the virus. They just have COVID present in their throat, same as if people suffer from meningitis, we would find up to 1 in 5 carriers. I really feel the way data is presented by the government is being framed to keep us frightened. I work as a practice nurse and feel frustrated that doctors have significantly reduced their face-to-face contacts, but phlebotomists and practice nurses frequently see patients, and I'll read the rest of it. Unfortunately, there isn't any more there. Which in some ways is a valid point, the different ways that we have contact and stuff. I think it's important to recognise that we have to have that responsibility for staff and for other patients. I keep coming back to this point. It's not just about the individual, and we have to try and do our best. And sometimes our best means that it upsets people. But that's the way it is, I'm afraid, to some degree.
It's a good point that was made there, actually, because this is a point that my practice nurses make to me. They say, okay, well, we've gone back to doing smears, and we've gone back to doing wound checks and dressing changes and these sorts of bread and butter nursing activities, and patients are being booked in directly for that. The receptionists are making that inquiry about COVID symptoms, and if there's any indication that there's COVID in the household or there's been an exposure or they have COVID symptoms, then no, that appointment is dealt with differently, normally by a telephone triage or just postponing it if it's a routine activity. But the nurses are seeing a higher proportion of well patients who, in an environment where COVID rates are going up, may well have COVID, whereas the GPs currently are triaging everything on the phone first and making their own risk assessment. And there is a little bit of an inequality there, really, in terms of risk exposure, which I think is worth mentioning.
I'd argue as long as that risk assessment is done, then it is in some way no different, because if I was assessing a patient, as long as I've done that relevant risk assessment to understand what that patient's symptomology is, and then book them in for a face-to-face, that's kind of no different to our reception teams asking those same questions. The issue comes in the honesty of the patient, or the awareness of the patient to understand the questions they're being asked and the implications of it, so that then it's booked appropriately. And I say that we've had a couple of contacts recently where patients have said that they don't have symptoms of a new cough, temperature, etc., when actually when you go back through the notes just a day or two prior, that's exactly what they've contacted us about when they've come for routine healthcare, things like smears and injections and that kind of stuff as well. So it's just understanding, why was there a different answer given? Is that because of the understanding of the questions? Is that because of the motives of the patient? Have they just forgotten? I think there are those elements to be aware of, and there are going to be times when we just get it wrong, because humans make error. Let's be clear on that point. We're never infallible. Even, what would life be if we were? But there is that element of understanding the access and stuff from there. Go for it, Andy.
I was going to say, I've got the voice of my practice nurse in my ear saying, well, but Andy, it's about volumes of patients that are seen, and that on your clinic you're bringing back a certain number of patients, but I'm doing a cervical smear clinic, and all of these patients are booked face to face. The patients you're seeing, yes, they've been screened so that they are not symptomatic of COVID, but they might have COVID because there's a high level in the population. And my patients have been screened potentially to a similar quality by the reception team, and they don't have COVID symptoms and they're coming. But I'm seeing 3 times as many patients as you who actually potentially might have COVID because it's circulating in the population. There is an inequality there. That's what they'll say. But notwithstanding,
and hence why our infection control policy procedures need to be clear about protecting both our patients and our staff, like wearing a mask and hand washing and social distancing and reducing contact and everything else. They will still likely need to continue, which is kind of what we've discussed and things. I guess just to emphasize it, so a few other people are clearly, I think, probably feel, in our view, so agree that initial remote consultation is the best way forward in terms of managing capacity and issues. Jitin, again, remote consult is the way forward. Again, Jitin mentioning no double jab and double tested. I'm handing in my antibody test. I'm not quite sure what that comment's about, but again, to emphasize that just because you've had both your vaccinations doesn't necessarily mean that you can't carry COVID and pass it on to somebody else. And it doesn't mean that you can't potentially have an infection from it. It just hopefully means that you have a less negative outcome from capturing it and things. But before we finish off, there was one other area I thought was really important we talk about, and that's masks in the future. So obviously we're talking about Freedom Day, whatever that means. Let's be clear, we've always had freedom in the UK. We are by no means subject to some of the issues in democracy that other countries and places face and stuff. So to be honest, I'm slightly frustrated by the concept of the whole naming of Freedom Day. But anyway, that's a separate matter. But what about, say, for example, in a year's time, when hopefully COVID is, part of the past, and we are heading towards whatever the new world is after that and things. What does that mean for healthcare in terms of mask wearing? I know I've got my views on this, Andy, but did you want to jump in first?
Well, I think we can look at other parts of the world that have suffered worse with previous pandemics. So if you look at the Far East, who suffered more with the SARS pandemic a few years ago than we did in the West, and one of the and I think they suffer with a few of the respiratory pandemics, actually. And one of the legacies there is that people, even after those pandemics are finished, would increasingly wear face masks in public to protect other people and protect themselves. If you travel in that part of the world on public transport, it was commonplace to see people wearing masks. And I think that myself, like other people, maybe from a Western perspective, are like, oh, these people are very risk averse. This seems like an unusual behavior. But actually, I am interested to see how much mask wearing in certain situations sticks in the West, and whether it will do in the same way as it has in those Eastern countries following the SARS pandemic. And I'm going to predict, I think it will. I think we're going to see increased mask wearing going forwards. Not from everybody, but from certain people who have a certain level of feeling of responsibility or risk attitude, I think will wear masks and face coverings going forwards, when they've got a cough, cold, flu, and so forth. So I was just thinking initially, just look to other parts of the world. Yeah. What were your feelings, Gandhi?
So I'd take this from 3 different points of view. So the first is with, clinician to patient interactions. And my personal view, given the realizations we've now had with COVID, is that any patient attending the practice with symptoms of an upper respiratory tract infection or something similar along those lines should be recommended to wear a mask when they attend the practice. And that's something I'm going to be suggesting that we have as part of our practice policy, as part of infection control and protecting our patients and stuff, because how many times we've seen the video footage and images, even pre-COVID, of waiting rooms filled with people that are coughing, and then it's basically a petri dish for spreading infections and stuff. And you could argue, why have we not done this before? Well, we didn't realize it was a massive issue, did we? But actually, we now realize that it can be, and the impact it can have. So actually protecting our staff and other patients, should we not be recommending to these patients that, if you have these symptoms, that there can be, sensibility and protection of others, you should be wearing a mask when you have those symptoms. Not all the time, absolutely agree, not all the time. But when you have the symptoms, or when you're going to a crowded environment where you could potentially transmit it to other patients. So that's number one. Number two is staff. The NHS in particular has history of staff working themselves to the bone, even when they're not well, to try and make sure that things work effectively. I mean, Andy, how many times have you gone to work when you've had a nasty cold because you just felt you kind of had to, and you were still okay to function, but clearly you weren't 100%.
I have been to work with serious with latterly diagnosed serious life-threatening health problems. I've still been sat there seeing patients.
Exactly.
So we are silly when it comes to working when unwell.
And again, it's that concept of infection control. That potential clinician could then go on and infect various other members of staff, could go on to infect other patients, just by innocuous, transmission and stuff. So actually, is it sensible for them to wear a mask whilst they're acutely having those symptoms? They may still be well enough to work, but in terms of either changes to the way their role works when they're acutely affected by those symptoms, or the type of work they do or how they do the work, would that not be sensible, for example, to wear a mask if you all have a bit of a cough? So then you don't spread that cough to other members of staff and cause even more issues with work, to those who work in offices. How many times have you had to take time off because somebody else at work had a cold, And then the last one, this I think is going to be the most contentious one, is the hospital environment. I genuinely think all hospitals will need to really consider the fact that respiratory and elderly care wards may have to have masks on patients when they are admitted into hospital, because hospital transmission infections are one of the key reasons many elderly and respiratory patients actually, unfortunately, suffer negative outcomes. And as a result of that, is that not potentially a way of reducing the risk of infection to inpatients and hopefully improving the health outcomes for those patients as well? Surely COVID has shone a light on that particular aspect. Now, I don't know the evidence behind that. I'm not going to state I do, but it seems sensible to think that has an impact.
Be an interesting study to do, wouldn't it? Just take two respiratory wards, potentially with the same physical layout, one floor above another or something, the same types of staff, same levels of staff training. So take two healthcare, the elderly wards, respiratory wards in a hospital, make wearing masks on one ward mandatory, not on the other, track it for 6 months, look at the levels of hospital-acquired pneumonia, another respiratory illness that occurs while inpatients. That feels like a really good study that someone should do. It'd be really interesting to see the impact, because you get a lot of data about how effective masks are in general, and some very useful specific information about how that intervention using masks in that healthcare environment might, really reduce harm to patients going forwards. That's a really good point, Gandhi. Yeah, excellent. The other point I was going to pick up on as well was I think the impact in the workplace and on employers' attitude towards respiratory illness and staff sickness might be a legacy of this pandemic as well, because a lot of money and staff hours are lost due to sickness from a combination of people being away from work when they shouldn't, but actually there's this what is it called? When people are at work when they shouldn't be at work, and it results in spreading illness to other people and problems with their own performance and productivity.
Hero complex?
No, presenteeism. That's what it's called.
Okay.
Presenteeism, when people come to work when they shouldn't. And I think we might see a different attitude towards that actually, as a legacy of the isolation experiences that they've had, and many more employers saying, actually, no, don't come to work when you're sick. Work from home, because it's possible to do that. Or if you need to come to work, as you were saying, wear a mask. I think the NHS and healthcare environments where it's harder to work from home, where there are chronic staff shortages, and managers might have their priorities might understandably be on actually just being able to continue to deliver a service effectively. I think, unfortunately, we might see that less of a factor in healthcare environments than in other environments that are more kind of fiscally driven. But yeah, look out for that. I think that's a good prediction.
I'm interested to see what happens, and definitely keen to hear your views, EGP learners, in terms of what you think, particularly those last few statements in terms of the mask wearing in the future. What is it going to mean in your practice? What is it going to mean in hospital environments? What is it going to mean for our patients? And will they accept it as well, is the other part, because it, imminently, whilst COVID's still there, I think people will be more accepting that in a year, 2 years' time, what if you turn around to a patient and said that you need to wear a mask when you come to the practice because you've got a cough? That's going to be an interesting time, I think. But again, like I said, my suggestion would be looking at all the information we now have about how infections are, we had this information before, we just didn't pay as much attention to it. And actually, is it the safest thing to do? Yeah, that's my view anyway. Happy to take further questions and comments from our live viewers and stuff. We've got quite a few at the moment, so feel free to say hi and stick in your questions if you've got any. So we're kind of going to the Q&A section of this. I'm more than happy to try and take any questions that you guys have. Whilst we're waiting for those to come in, though, just a quick recap of what's going to be happening in the near future. So in 2 weeks' time, myself and Andy are actually going, hopefully, as long as nothing else changes with the pandemic and stuff, to the UK Games Expo. We're both a bit of board gaming fans and stuff, or geeks as well, let's call it. And yeah, we're going to be live streaming from there if we're able to. So it's going to be an interesting episode and contact, and you're more than welcome to come and join us. I know we've got some colleagues coming to hopefully catch up with us at the Games Expo, and it's all hopefully going to be COVID safe. There's lots of information about there about how to protect yourself and others, and really I've been through kind of their COVID precautions and stuff. It seems they're doing a really good job at trying to make sure that it's as fair and equitable to as many people, particularly since we don't obviously know what the guidance will be like at that point as well. So we're going to have a slightly different episode next time, and it may even be multiple streams on the same day. So definitely check out the EGP Learning channel at that point. What's your thoughts on the Games Expo, Andy?
Yeah, I'm really looking forward to it, actually. We've both been fans of board games for a long time. And I think they can teach us a lot sometimes about risk management and decision making. I think they're really good tools, and I think people should play more board games. They're also excellent ways of socializing with people, because you have to pay them face to face normally. So I'm really looking forward to that. I'm also looking forward to, as you say, being in a sort of a conference environment with lots of people. Not done that for a long period of time, so looking forward to experiencing that, and also seeing how other people are taking precautions, measures, just kind of see what that feels like in a semi post pandemic, end stage, hopefully pandemic environment. It's going to be fun.
Absolutely agree with the whole board game and stuff. So some of the EGP learners may remember I've done episodes with 10-minute. I've forgotten the name now. Mind blank. In terms of using board games for isolation and health and well-being, and actually it's something we're looking at with our PCN social link working prescribers to try and help patients in terms of social engagement and that kind of stuff, because there's so many skills that you can learn from board games. I've even used it as a teaching tool with some of my trainees in terms of understanding how to explain complex information, because if you've ever tried to explain a rule set for a complex game to new players, it's the same skills as trying to explain health information to patients. In some ways, it's the same skills you need. So definitely sensible to see. Cara's asked us for a zoom in picture of the stuff that we've got in our background, Andy.
I've got a suggestion here. So what we could do as maybe a recorded episode, we could do like a cribs episode and show people our setup, because I bet people might be interested in terms of like, what's the other side of the camera? What kind of equipment are we using? I've not seen your setup like throughout the whole of the pandemic, and you bought lots of new equipment and so forth. I just wonder if that's the answer to that question.
I think we might do that for next week then, because we're looking at content and stuff. So yeah, we'll have a look at that, Cara. So we're not going to show you zoom in now because it's a little bit tricky to adjust things whilst we're streaming live and stuff. Yeah, it just means moving cameras and upsetting the kit, but we'll get you a behind the scenes kind of look at all of our stuff and things and what they look like. And I must admit, I still prefer Andy's setup. That's partly because he's got a nice dedicated room for all of this. I'm kind of using our attic converted into a office stuff. So having to
I like your
review that.
sofa though, Gandhi. I'm jealous of that.
Nice sofa. It's definitely fun to sit on and stuff, and it converts into a bed. So it's one of the reasons why it's here as well. So we used to have lots of guests come up and stuff, and obviously hopefully that will happen soon. My sister and niece and nephew and things can come up. Interesting question from Jay Shapuri. So should primary care be provided with FFP3 masks? This was a massive issue when the COVID kicked off, because that was the view many people felt that we needed, and obviously the NHS England risk assessment and SOPs and stuff suggested that that wasn't really necessary, which I know many people disagreed with, and hence actually why partly visors became into play to offer double protection, but obviously remembering that visors only protect you from droplets, not from aerosols, and therefore we're mainly for eye protection and stuff rather than anything else. What do you think, Andy?
I think and the ability to fit test them correctly, I think, should be at the end of that sentence as well.
So I can't wear an FFP3 because of the beard. I'd have to shave off my beard if I want to wear an FFP3 mask.
I think where the FFP3 perhaps has more relevance, we were involved in setting up the what we call locally COVID management centres or COVID hot clinics, where you were seeing a selection of patients who were selected because they might have COVID. So actually a significantly more risky environment from a contracting infection perspective of the people working there. So I think FFP is more relevant, or particularly relevant in those high risk environments, because they were obviously used for certain procedures within the hospital, aerosol generating procedures, but not in those high risk environments, although also not on a lot of ITU wards where those procedures weren't being used. So I think yes, with fit tests, it's all about, it would be a gold standard, wouldn't it? But it's about the availability of the mask, the resources to fit test them, and actually whether those masks should be somewhere else rather than being in the GP practices if there aren't enough of them. And I think there's sort of a hierarchy of environments that might need the FFP3 masks first, but I think general practice should be on that list, but it's not right at the top.
Interesting point from Jez, though, in terms of for spirometry especially, potentially, because obviously spirometry is considered an aerosol generating procedure. I guess important to recognise spirometry is not actually part of the GMS contract. So first thing, actually, general practice is not required to do spirometry. Annoyingly, in some ways, you could argue that it is, because in order to fulfill some of the QOF requirements, you have to have a spirometry reading, and the hospital-based spirometry services have unfortunately not been to the depth and level they needed. And obviously during the pandemic, they pretty much stopped, because it is considered a sort of generating procedure, and to do that safely with the equipment that we have is tricky, to say the least. I know that we've got a list of people needing spirometry for either for diagnosis or for management, and I think that's Jez also makes that point and stuff.
I help restarting the spirometry.
But interestingly, the new guidance around the use of spirometry means that most places will need new equipment, because they'll need new filters. They'll need retraining, because so many people haven't done it in such a long time, and the training process is crazy. 6 months to train how to do spirometry properly. I think that's going to really impact the deliverability of healthcare services.
I think the training providers are making money.
Separate issue, and obviously not one that we should be getting into in some ways at this point, particularly with so long into the stream. But I think unfortunately one thing that is going to come out of the pandemic is that spirometry delivery services is going to significantly be different to what it was pre-pandemic, because I think a lot of practices are going to turn around and say they don't have the capacity or the capabilities to deliver spirometry in practice anymore. Does that lead towards the whole concept of PTN level setups and other kind of things? I think that's likely to happen. But obviously important to also remember that it is not part of the GMS contract.
No, that's very true. Yogesh Patel has sent us some messages about the FFP3 masks. I'm just eyeballing those. We should.
You can order them on Amazon if you want. They're readily available. Okay, maybe
insufficient quantities, I guess, is the question for widespread use in healthcare. But you can get hold of them. I've got one in my kitchen ordered on Amazon. I'm saving it for when things get really bad. And then
fingers crossed we don't get that away, pending obviously Boris's suggestions and stuff.
He's also said we should have hot clinics and so forth, and that's something that we had in Nottingham. Interestingly, being stepped down at the moment, with responsibilities for assessing and managing hot patients falling back on general practice and primary care networks. But we had the luxury of that facility in Nottingham for a while, provided by a local federation in collaboration with CCG and primary care networks, which was good.
Cool. So thank you everybody for joining us for this really interesting session. We've really enjoyed the discussion, and hopefully you have too. As ever, if you want to catch any of the content, listen to the podcast, listen to our other streams and stuff. We've got loads of content out there for you. Definitely subscribe if you're watching this and stuff, and hope you get all of our content first and foremost. And as always, we're here to tech enhance your primary care and learning, and we will catch you in the next episode, which will be live from the UK Games Expo.
Exciting.
Yeah.
See you guys. Bye-bye.
See you later. Bye.